Good morning. I am waiting for Facebook to catch up with us, Instagram Live, because Facebook is not live quite yet. Okay, we're live. Good morning, PT on Ice Daily Show. I am Dr. Lindsay Huey, lead faculty for extremity management, along with Eric Chacones. Welcome to Clinical Tuesday. It's my delight to be here with you again. And today we're going to talk about creative dosage for subacromial shoulder pain. We have all had that patient with that anterior lateral shoulder pain. I'm not talking about the radiating kind that has to do with like lower cervical dysfunction, but straight mechanical shoulder pain. It has many names: rotator cuff tendinopathy, impingement syndrome, subacromial impingement syndrome, and more recently, rotator cuff related shoulder pain. And you heard me say one of the things was rotator cuff tendinopathy. So if it's a tendon issue or a tendinopathy issue we're dealing with, then we have to really load those tendons. And while I think as physical therapists, we do a great job in that concentric phase of loading for subacromial impingement, we could do better in our isometric and eccentric loading. And we're going to talk about kind of what I use in the clinic in my eccentric loading program. But first, let's just do a little literature review of what it actually says about eccentric loading, and then just exercise in general for this condition. So a recent update in JSPT by Peters et al. Just did an update on systematic reviews, and validates that exercise is that primary thing we want to do for subacromial shoulder pain. In the early stages, we want to pair that with some great manual therapy. And if you come to Eric or I's courses, we'll go over those manual therapy techniques, like the little plug for our course. Get scheduled for either the remainder of this year or next year on ptonice.com. But getting back to the point, but then also, so we're talking exercise is validated for this region, but the specifics are not there. And basically at the end of all systematic reviews and meta-analysis for shoulder pain, there's a call for dosage, because there's not a lot known about our dosage in regards to reps, sets, frequency, and then just overall duration. So that systematic review, in which I will post it for you guys, says exercise is great, but we don't know how much and for the duration. And then when we look specifically in the literature about eccentric training, a systematic review and meta-analysis by Larson et al. Came out in 2019 in the BMC Musculoskeletal Disorders Journal. And when it looked at 7 articles, all RCTs for eccentric training specific to subacromial shoulder pain, whether it involved supraspinatus eccentric training or external rotator eccentric training, it actually found that there wasn't a big difference between concentric training and eccentric training, which I found to be a major bummer, because I've actually seen eccentric training to be the thing that actually helps reduce pain and improve function with my patients. And so if we take a deeper dive into that systematic review and look, again, it was only 7 articles, right? So not a big body of evidence. We can learn something from those 7 articles, what was done. So in regards to frequency, it was anywhere from 5 days a week, 1 to 2 times a day, where 12 to 15 reps were done, and actually 3 sets usually. So all these articles use that similar dosage. And that's very similar to what we know about lower quarter tendinopathies and loading. That's a very similar rep scheme. But what wasn't really expounded on in the articles were, what does the eccentric phase really look like in regards to time? And our own Dr. Chacones actually was the only article in that systematic review that noted a 2-second isometric hold and then a 3-second eccentric phase. But all the other articles didn't really note what that eccentric time was. And so that's where I feel like we can grow as physical therapists in really being intentional in our isometric and eccentric phases. And so going back to what the systematic review said was maybe it's that all of these articles didn't actually dose intense enough. So dosages were anywhere from 65% to 80% one rep max. Nothing really looked at above that. So this article was a call to let's actually load eccentrically above 80% your one rep max to actually see if that's more efficacious in reducing pain and improving function. And again, the article's conclusion was there was a slight decrease in post-treatment pain with the eccentrics, but there was not really a big change in function. And if you look at each of those RCTs individually, you can see that there are some improvements in function, but again, overall the body shows not very clinically significant. And so here is where I want to share with you a little bit more about my dosage that I use in the clinic. And then I actually would love to hear from you of what dosages you have found have really helped with your patients, and on Facebook or Instagram Live, kind of sharing your clinical expertise, because this is where we're falling short in the literature pretty consistently in that our dosage, we just don't know. And that comes from every patient is very unique, right? So every patient's going to need to be a little bit different and varied. But what I think what we can learn from that systematic review is just that general rep scheme, and then we can manipulate it according to our patient. So that rep scheme of 12 to 15 reps, 3 sets, 1 to 2 times a day, 5 days a week. And that is a lot of loading, right? So the concern is often, and why we may shy away from eccentrics, especially in the acute phase, is we don't want our patients to be in more pain, right? We want them to come, we want that buy-in, we want to keep them with us, and we want them to get back to their function faster. And so I think what we need to do is be better at intentionally combining isometric and eccentrics in the acute, subacute, and chronic phases of subacromial impingement. And specifically training that supraspinatus and then your external rotators. So I want to share with you what acute and high irritability dosage looks like for me in my clinic. So someone comes in, and we're going to just be very broad here, but acute and highly irritable. If we follow the lower extremity dosage, and a lot of that information comes from Dr. Jill Cook, they would recommend a 45-second isometric hold, 5 sets, which is a total of 220 seconds. I don't know about you, but in the shoulder, that is not, especially a highly irritable shoulder, my patients aren't always game for that. But I'm still going to have that goal of 220 seconds. So it might look like maybe I'm doing 20 reps of a 10 to 12 second hold. And the other thing is, I think we always think about your typical, and I'm going to just grab a prop. That's for you, Alan. We think about the isometric against the wall exercise, right? And that is effective, and you can do the 45-second hold, 5 sets, or like I said, split it up for the more irritable patient, and it could be 10-second hold 20 times. Or maybe we could fire that whole rotator cuff and work on endurance by just doing a farmer carry. So we take a heavy kettlebell, or if you're doing home PT, whatever, something heavy, a bucket, and fill something with it, and you just hold. And for those that can't see me right now, that aren't on Facebook or Instagram Live, I'll describe it. So farmer carry, we're just holding, or a suitcase carry, it's also known. The way this is effective, though, is not just in the dosage prescribed, but how you're doing the exercise. So am I doing a lazy shoulder where my shoulder is depressed and it's not engaged and my midline is shifted? So that's not what we want, right? We want midline engaged, rib cage down, and we want that shoulder active in a retracted position and nice. And if you can't see me, again, I'm just holding with a more active shoulder where my shoulder is engaged. And maybe I'm just doing holds if the patient can tolerate the 45 seconds, 5 sets, or maybe again, it's that 10-second hold, 20 reps, and we'll take breaks because grip endurance is a factor. But what I love about this is it's also incorporating midline control and stability. And you'll find actually that the analgesic effects are really powerful in just a hold to calm down that shoulder. And again, we're talking about the person that is complaining about that anterior lateral shoulder pain associated with probably about that 45 to 120. That painful arc is really common. And when they're highly irritable and acute, you might not be able to spend as much time in that painful range. So staying down low and activating the cuff really helps. And again, it's fine to do the traditional against the wall. I still use that, but just giving you some other ideas to do. Often this population also might complain of that 170 degree to 180 abduction pain. So that you also want to train the abductors, right? That supraspinatus. And so again, you can do the wall, right? Or if they're able to, so now we're starting to move into that subacute moderate phase, once you've restored range of motion, and through some manual therapy techniques, active range of motion, you can start to also do an isometric hold in the positions they can tolerate. So maybe they're better in that mid-range, so maybe you'll do an isometric hold at mid-range with kettlebell up. This could also be with a dumbbell, it could be with a weight, it doesn't have to be a kettlebell. The kettlebell up just makes it harder. It could also be with just a ball, right? Just holding out. But I think if we do a better job at, and all I'm doing right now for the people that can't see me, and if you're listening to the podcast, I'm holding out a ball into flexion at about 90 degrees and then 90 degrees of abduction. But trying to get to that 45-second hold times 5 sets. And I keep repeating that over and over again, just because I think we can do better. And I can reflect even 5 years ago in my career, not really being intentional at all about my isometric holds, maybe 5 seconds, 5 reps, 5 seconds, 10 reps, 3 sets of 10, with really not much rationale behind it. And so this is a call to have rationale in both phases. And as I mentioned, as we're getting into that subacute phase where there's less irritability and we can be a little more aggressive, I like to combine all the phases of a muscle contraction, right? So I might have a patient with a dumbbell or a weighted ball go up through that pain-free range and do concentric contraction, then hold maybe 5 to 10 seconds in that isometric place, and then spend double the amount, maybe 10 to 20 seconds going through that that eccentric lowering phase. To refer back to that systematic review that we looked at, or that I mentioned by Larson et al., the only RCT, again, that mentioned phases was Dr. Eric Cicconi's, where it was a 2-second isometric and then 3-second eccentric. But I find that if you're more aggressive in those prescriptions, so even longer dosage, you tend to get out of that subacute phase faster. And always building up to that 3 sets of 12 to 15, 1 to 2 times a day. Another way I like to bring intensity is maybe doing in a remom fashion. So Dr. Mitch Babcock came up with that concept. Every minute on the minute is a common CrossFit workout, but then actually incorporating this in the rehab setting, which a lot of ICE listeners are really familiar with and already using. But I really love using it for subacromial pain, because I can incorporate not only eccentrics for ER and abduction, but then I can also throw in some thoracic mobility work like thread the needle, and then some quadruped Y. So I'm also working on scapulothoracic training, because that's all a part of the person. I'm talking very isolated today, specifically external rotators and training the supraspinatus, so training abductors eccentrically, but also consider the full picture of when you're treating this condition. You also have to incorporate everything else. Now, moving into if I'm thinking about chronic phases where they have low irritability and maybe actually fluctuating irritability, meaning sometimes they're up, pain's really high, sometimes it's low, and it's kind of hard to predict. Again, being more intentional in our isometric and eccentric dosage, I think, is really key. And then varying what you do in a session. So, that varied functional fitness that CrossFit advocates, I've really let that permeate into how I treat. And so I'm going to make with it whatever we're doing in that session be very different each session. And so then how am I always going to achieve that, 3 sets of 12 to 15 reps? That's something where, because we know that has been relatively efficacious in the lower extremity, it's something that you need to actually put onus on the patient to be doing that in the background, right? So 5 days a week, Ms. Jones, I really need you working on, and it's your pick, whatever you want to do for external rotator strengthening, whether it's with a band, but I would encourage it that it be eccentric. So teaching them how to get it to that part. So get it, if it's external rotation with a band and standing, teaching them how to move it so that they don't have to do that concentric phase, and then slowly going into that eccentric lengthening phase, and then being really specific at how long you want them to hold isometrically, and then how many to do eccentrically in that lengthening phase. But having them know that it's not just that 1 to 2 days a week that you see me that's going to make a difference. You really have to load intentionally at least 5 days a week. And again, depending on if you're acute, subacute, or chronic, it's going to vary your dosage. And I would say the more acute, you're doing more isometrics, and the more variability in the irritability, you are doing a bigger mix of isometrics and eccentrics. But in that sweet spot of low irritability, let's say be more aggressive in your eccentric training. And that call for greater intensity, you can do in the form of that 70 to 80 1 rep max, percent of 1 rep max. And the way you can dose that in the clinic, because we're not 1 rep maxing our external rotators and our supraspinatus, what you can do is use an RPE scale. So anywhere from 7 to 8, or you can use reps in reserve, where you should have like 1 to 3 reps left in you until you can do another. So these are just some ideas that I wanted to share with you in how I do my dosage. And I wanted to just give, for people that are watching, give a little visual, and I know it's going to be reversed on some, but like what a REMA might look for me. So I would do eccentric ER, and I would do that maybe in side lying or even in sitting with a weight. And then I would do thread the needle for another minute. The 3rd minute, do full can abduction, really focusing on like a 6-second eccentric lowering, and then quadruped wise, where the patient's alternating in quadruped to really engage lower trap, which we know is often inhibited in this condition. And you're probably sick of hearing me talking by now. So finally, I just want to challenge you, and you probably, every time I get on here, I'm going to challenge you about dosage and being really intentional about your duration, your frequency, and being very specific with patients, because you always hear Dr. Jeff Moore, our CEO, say excellence looks different. And if you're following any of his recent personal things he's been saying on his Facebook page or Instagram about being on that offense, right? So if we want to make our patients well and we want to make them resilient, we have to be very purposeful in our dosage. And each time we see them, plant a little seed of what resiliency looks like. You might only have a month with them, but know that it takes anywhere from 6 to 12 weeks to see these great changes and to see full return to function. So letting patients know that they're going to have to put in the time, and you're going to give them the tools and the plan, but that it does take time. And then letting them know how they can be well in the long run so that they don't have to come back and see you for that shoulder. Well, I really appreciate your time and attention today. Please feel free to comment on what creative dosage you've used for isometrics or eccentrics, and I will post links to the information on the systematic review in JOSPT and in the BMC Musculoskeletal Disorder Journal. So thanks for your time. Happy Tuesday. Bye, guys.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.